It's great to have everyone here today, and my name is Sandy Boehm. And Ron and I we've worked together a lot, and it's an honor to be here. It truly is. If there are questions, please feel free to ask. We're getting into this interactive session, which is what Ron and I would love to do as we go through our series. And that's where we all learn from each other. We always learn from each other, and that's a key issue for me. This next segment, which is session 2, is entitled Developing a Management Strategy. Okay, so we'll continue on. So let's discuss our first case, Mrs. A. And as you notice, this goes back to the initial cases, same cases that we'll take up, but we're looking at a different aspect of their assessment and treatment. So as we recall, Mrs. A is a 67-year-old, Mr. A is a 67-year-old male, Caucasian, 2 weeks referred by ortho, post-hip fracture sustained after tripping over a small rug in his bedroom. So he has active physical lifestyle, travels, well-balanced diet, severe GERD on omeprazole, no smoking, no other risks, at least from that. Exam, no height loss. Profile is there, normal, meaning a routine profile, and is on Ambien as well. No other drugs, family history negative for osteoporosis, T-score minus 2.7. And so the question is, the following is or are true about bone turnover. So firstly, is bone mass affected by the rate of bone resorption and bone formation? In children, bone formation exceeds bone resorption. In adults, bone formation is equal to bone resorption. After menopause, bone resorption increases and exceeds bone formation. So what do you think? There's only 8 people here in the audience that have clicked. So should I go through this again? All right. I'm not going on. We're going to stay at this one question for the next 2.5 hours unless I see 40-some clicks. How many people?
That's 25 is about normal. 25 is.
Oh, what about the other folks? They're not clicking? What happened to the other 20-some people here? You're not clicking. Oh, okay. All right. So yes, this is true. So as we develop in life through puberty and adolescence, we're modeling bone. We have increased formation, and so we have a net positive bone accrual. And certainly during normal adulthood, we have a net zero. So we resorb bone, we form bone, we have the net zero effect. So we don't lose bone. And as with the postmenopausal time frame, we have accelerated bone loss. And with age-related bone loss, we see approximately a 1% loss per annum in folks with increased resorption over formation. So even though bone formation and bone resorption as part of the remodeling process of bone is coupled, they're coupled, our bone cells talk with each other, they talk with each other. Resorption is greater than formation, so we don't fill in those resorption sites in our skeleton, leaving us with a net negative. So the balance is not there as in earlier adulthood. Okay? Next question. The following is or are true. Anti-resorptive medications inhibit the activity of osteoclasts. Osteoanabolic medications stimulate osteoblasts. Anti-resorptive medications include bisphosphonates, denosumab, and raloxifene. Teriparatide is the only FDA-approved osteoanabolic medical therapy, or all of the above. Please feel free to do your clicking. Don't be afraid. No one's watching you. They're watching us up here. We're getting, see, look at this. Don't be afraid. I want to see 40-some clicks. So the answer is E. So it's true. So anti-resorptives affect osteoclastic activity in different ways, though. They're all different. So bisphosphonates are different than denosumab and raloxifene. They work in different pathways to decrease osteoclastic activity. We know that there is coupling of resorption and formation. This is a coupled process, but resorption, when it declines as part of drug therapy, also decreases bone formation, but to a lesser extent as compared to osteoclastic activity. So we have increased formation and mineralization in the remodeling spaces that are there. That's how anti-resorptives work. They fill in the remodeling space, those resorption bays that have been dug out by the osteoclasts. The osteoclasts are inhibited. The osteoblasts continue to form some bone to fill it in as much as they can, and that's how we have increased bone density with the anti-resorptive medical therapies that are available to us. They also decrease stress risers. They decrease remodeling rates dramatically. In some cases that we'll talk about, within days of intervention, we see decreased osteoclastic activity. The osteoanabolic agent, teriparatide, is a direct osteoblast stimulator. So it's a small segment, 1 to 34 of teriparatide, as it's called, which is PTH, and it works directly on bone remodeling in regard to osteoblast formation. Okay, and that's how they differ dramatically. All right. In Mr. A's case, the following are recommended: any orally administered bisphosphonate, zoledronic acid, which is called reclassed, teriparatide, which is called Forteo, denosumab, which is called Prolia. Those are the trade names. B, C, or D. So most of you, let's see, what do we have here? We're going back and forth. Now, this is your patient. You have to make a decision. You can't just sit there. You got to click. Ron, would you go around and make sure everybody clicks? Okay, we were up to close to 30 people before. People don't know what to do. Is that it? Okay, we're getting better. We're moving ahead here. So we're getting close. So look at the patient's history. What sticks out? Exactly. Perfect. Thank you. So the patient has severe GERD, is on omeprazole for this. Would you really want to provide the patient with an oral bisphosphonate, which one of the significant potential risks is gastroesophageal, upper gastroesophageal erosion and bleeding? Okay, and so you would not potentially utilize this unless it was the only medical therapy available, but you wouldn't want to use an orally administered bisphosphonate. Yes?
Are you having trouble with insurance coverage? Because I have patients like this. I try to document in their note they have severe GERD, not a candidate for oral therapy. Then I have the insurance companies telling me they have to fail 2 therapies. And I even called them, and they said unless I can show that they had Barrett's esophagus, they want them to try an oral, or I can give them.
Yes, please. Pardon me? Yes, it is a big problem. Yeah, it is a problem because, of course, why do you think that is occurring? It's all about the cost. So you can get a Lendernate for, in some places, at $4, a month, or $4 a tablet. So it is all about cost and reimbursement. So, they're playing their game. And unfortunately, I don't have any control of it, but you can fight with them. You can go, what I've done is gone directly to the medical director of your local, administrator, the local medical director, and say, then you're going to take responsibility if the patient has a GI bleed. You can also do stool guaiacs. You can send them to GI and have them scoped, beforehand also. And yes, there's some small erosions. Now, do you want to still use oral bisphosphonate in that patient? So there are ways of attempting to procure the medical therapy for your patient. But it is difficult. I agree. Okay?
Worst case scenario, you may want to try the patient for a couple of weeks and notify the patient that I don't really like doing it, but your insurance is not going to pay for it. They are the ones who insist that you go on an oral and warning the patient that it may backfire. And most of the time, the patients are quite happy to say, okay, doc, I'll go for 2 weeks. Let's see how it goes. And then you're on a much stronger footing to say it's causing a lot of GI upset. Another reason for not to go for the oral is that the guy travels extensively. And compliance is not likely to be very high, knowing the procedure involved around taking the oral bisphosphonate.
Okay. So let's discuss zoledronic acid. Zoledronic acid is a bisphosphonate. It's administered IV once a year. Administered IV infusion 4 milligrams every 3 to 4 weeks, or AB or ABC. Okay, so we have the majority of people saying A and B. So this is zoledronic acid. It is a bisphosphonate, as we've stated, the most potent bisphosphonate. It's certainly administered by infusion. In the generic term for osteoporosis therapy, it's called reclast. Okay, how many have used zoledronic acid reclast? So a majority of you. Many of you may not be aware that it is also utilized in neoplasia for skeletal-related events, for hypercalcemia in patients, and the dosage is 4 milligrams every 3 to 4 weeks. That is utilized in alternative dosing depending upon creatinine clearance in those patients with malignancies. So it is used also for malignancy. Zoledronic acid should not be administered with a creatinine clearance that is less than 35 ml. Calcium is elevated, serum calcium is low. A and B or A and C? What do you think? We're getting close. All right, so we have 26, 27. This is good. This is good. People are making decisions. So the key issue in this case is that less than 35, we do not utilize zoledronic acid. So early on in the treatment of osteoporosis, it was given quickly, IV push. And there was a significant notation in the literature of acute tubular necrosis and other types of acute kidney injury that occurred with it. And now it's given, we give it over at least a 30-minute period of time, IV. And that is to lessen the load because 50% is absorbed to bone and 50% comes out through the kidney. And so the limitation is 35 ml per minute creatinine clearance. Serum calcium is elevated. Well, it's given also in individuals with hypercalcemia and skeletal-related events. Serum calcium is low. You wouldn't want to do that because, as we'll discuss, there is the potential of hypocalcemia associated with bisphosphonates, especially the IVs. Because remember, we're turning off bone rapidly. And one of the ways that we keep our calcium levels in the normal range is through our calcium regulatory pathways, which include bone resorption. And if your patient has baseline vitamin D deficiency, secondary hyperparathyroidism, low normal calciums that have never been checked, meaning an ionized calcium has never been checked, and you provide that patient with a drug like this, you could be in trouble. And tetany has occurred, death has occurred, arrhythmias have occurred in this setting. So it's important to check your patients for these potential etiologies and make sure they are, at least when they're vitamin D deficient, replete. And they have adequate calcium coming in through their diet or supplements, whatever. Because this can occur and has been published. This is published data. So I think this is really a key point for us to remember. It's been shown to reduce hip fracture risk. Okay? So as this been shown in postmenopausal women with osteoporosis, men with osteoporosis, women and men who have sustained an osteoporotic hip fracture, A and B, A, B, and C. Please choose. So we're talking about indications, and is it really effective in these clinical settings? Very good. And that's correct. So the majority went with the correct statement. And so it has been shown in prospective trials, registration trials, that it works in all categories and was actually provided patients as part of an admission for a hip fracture. So patients admitted to the hospital with a hip fracture were also provided reclass, zoledronic acid 5 milligrams IV, and found to have decreased future fracture risk and all-cause mortality, about 27%. Yes, please.
Do you provide patients with drug holidays?
We'll discuss that. The question is use of drug holiday with reclass. We will discuss that at great length in the future. Thank you very much for an excellent question. If we forget, I want you to ask that again.
We'll talk about it.
Yes.
Next session.
Yeah, next session we'll be discussing that. And all drug holiday, we'll discuss all of that. Okay. Now, compared to placebo, in postmenopausal women with osteoporosis, zoledronic acid reduces the risk of hip fractures by 41%, new morphometric vertebral fractures by 70%, non-vert fractures by 25%. So your patients ask you, does this stuff really work? What can I look for in the future? Or usually the family asks the question, how effective is this drug for the treatment of osteoporosis in my loved one? What do you think? You think everyone's following the lead here? The first 10 people?
It's majority rules.
Yeah, I think so. So the answer would be correct. It reduces fracture risk in all population, in all of the three different endpoints that we're looking at. In patients who sustained fragility fractures compared to placebo, Zoledronic acid reduces the risk of clinical fractures by 35%, overall mortality by 28%, significantly increases the BMD at the hips and lumbar spine. Please choose. Okay, so as I mentioned earlier, there have been a number of studies, but specifically zoledronic acid used after hip fracture admission. And during the admission to the institution, prior to discharge, they're given zoledronic acid, and they're observed then in the future for future fracture risk. And what they found was it definitively decreases future fracture risk, but also all-cause mortality was decreased with zoledronic acid, meaning there was decreased mortality post-hip fracture. So this is a true statement. There are other studies also that have been published that looked at all bisphosphonate therapy, including orals, and this is also disclosed, decreased mortality rates as well. Okay. Zoledronic acid administration is associated with significant increases in BMD in the following patient categories: postmenopausal women with osteopenia, patients on aromatase inhibitors or undergoing androgen deprivation therapy, patients with bone mets. A and B, A, B, and C. Very good. So the majority have it, and so it has been shown, and actually there was a head-to-head trial with zoledronic acid, which has been used for quite some time with skeletal-related events, with denosumab. So a head-to-head trial using both medical therapies have been shown and published. Adverse effects of zoledronic acid include GI side effects, acute musculoskeletal pains, adverse ocular effects, B and C, A, B, and C. And so we want to know some of these adverse effects because the families and the patients of ours are going to ask, what can I expect? What is the risk with this medication? So we're still thinking about it here. This is good. These are excellent discussion points. So first of all, we know that they're given IV, so we're not going to have esophagitis, GI bleeding, and significant adverse effects that way. So A, obviously, doesn't occur with IV therapy. We know that there is an acute influenza-like phase reaction that occurs with the IV bisphosphonates, and even denosumab has been seen. And I've also seen this with bisphosphonates, oral bisphosphonates, where there's an acute phase reaction due to cytokine release as part of the bisphosphonate effect. And so acute musculoskeletal effects may occur. There are rare cases of ocular adverse reactions, and these are very rare instances. And some of these have included like uveitis, episcleritis, and a variety of conjunctivitis. And the mild forms like conjunctivitis usually resolve on their own. Otherwise, you would have to consider an ophthalmologist to see the patient in these cases. They're rare, but I think we have to include these when we discuss potential risk with our patients if we're going to use these medications, because then we would want to know how to address these issues if they occurred. Let's talk about the acute phase reaction. So it affects about 20% of bisphosphonate-naive patients, affects 10% of patients who have been exposed to bisphosphonates, is reduced by 5% by intake of acetaminophen, etc., A, B, or C. So you need to know this because these things can happen. This is not an unusual adverse event. If you're going to use medical therapy, we have to explain to the patient to potentially moderate that adverse effect if we can. All right. So in this case, we can see that most people chose all three. So this does affect a significant number of patients that are on IV therapy. Again, this is an acute phase reaction. It could be a febrile illness, it could be myalgias, arthralgias. Patients feel lousy. It occurs after the infusion, 24 hours or so, or even sooner in some patients. It lasts for 48 to 72 hours in most cases, but I have not seen, but it is, yes, I have seen up to a week to 10 days in some patients, and there are reports of over 12 months in some patients after this. So that these are not infrequent. And I characteristically suggest to my patient, if they've never had IV therapy before of this nature, to take Tylenol, acetaminophen, I should say, or a nonsteroidal prior to their infusion every 4 to 6 hours thereafter, up to the maximum dose of acetaminophen, of course, or nonsteroidal, to potentially ameliorate that reaction. Okay? So that's really a key point. As you continue to utilize medical therapy such as this, the frequency of occurrence actually decreases. So with the second infusion, it's less than the first, and the third is less than the second. So there's a diminishing potential for the acute phase reaction with IV therapy. Now, additional adverse effects of zoledronic acid include AFib, nephrotoxicity, hypocalcemia, B and C, A, B, and C. So as we've talked about, and it's obviously the question is whether atrial fibrillation can be associated with this drug treatment. And so we've already talked about how nephrotoxicity can occur if you give it IV push. Okay, even with the agents that have been around for a long time for the treatment of hypercalcemia, like pamidronate IV, that also the dosage of that has to be moderated or changed depending upon kidney function also, and the dosage changed, how it's delivered over 4 hours, up to 24 hours, or split between 2 days for hypercalcemia malignancy. So there are different ways of manipulating the dose route and how you give it in patients above 35 or greater milliliters per minute in creatinine clearance. Hypocalcemia we've talked about. But atrial fibrillation was actually found in the original FREEDOM study. That's what the study was called. The 3-year registration trial that was continued for long-term trial. And so there was an increase in atrial fibrillation in these patients. However, they looked at the long-term trial and found that there was very little of this, and all the trials with this medical therapy, and found there was no increased risk of atrial fibrillation. They did a complete meta-analysis of all bisphosphonates, including alendronate and risedronate, as well as the IV therapies, and found no increased risk of atrial fibrillation with these therapies. Many of these patients had underlying cardiovascular diseases that developed it in the initial registration trial of 3 years. Okay. Ron, any other comments? Okay. All right. The following are also recommendations in Mr. A's case. Discontinue zolpidem. Prescribe hip protectors. Do a full workup to exclude multiple myeloma. A, B, and A, B, and C. We still have a few people out there that have to do their clicking. We're getting close. All right. Well, let's talk about this. So, would you discontinue Zolpidem, Ambien? Well, Dr. Hamdi talked about this. We know that sedatives, hypnotics, narcotics are certainly associated with altered mental status. This patient, if we look back in his history, he tripped over the small rug in his bedroom. So he was potentially sleeping, got up, went to the bathroom. So you certainly would want to discontinue this if you could, okay? Or taper to the lowest possible dose. But I taper off this drug therapy and suggest to the patient's family that this is dangerous, okay? For the patient. You could prescribe hip pad protectors. So these are, has anyone seen hip pad protectors? Have anyone used them? You've used them? Very good. What do they look like?
They are, well, the ones I use are called Safe Hip.
Okay.
They have an 11 millimeter plastic insert on both sides that spreads the pressure out away from
Beautiful. Anybody else use hip pad protectors? Everybody's shaking their head. I don't know what this means. Ron?
I use them
How often do you use them?
quite frequently. And they're not really that disfiguring. They're quite handy to put. The main problem, however, is that the patient would wear them all day. She goes to bed, takes them out, wakes up in the middle of the night, wants to go to the bathroom, postpones it as much as possible. Eventually, the urge to go to the bathroom is such that she has to rush, gets out of bed, rushes to the bathroom, forgets to put the pads on, falls, and breaks the other hip. So as long as the patient is wearing them, they're quite useful. They're not at all difficult to place. Now, the problem is if you look at some of the published data, there is no effect, significant effect on fracture risk reduction. But if you look at the studies and look at the analysis, most of the analysis were done by an intention to treat. And if you start looking in the details, most of the fractures that occur in patients who are on hip protectors occur while the patient is not wearing the hip protector.
And I think that's a key point that Ron had mentioned. It's not only hip protectors, it's medical therapies. We know with all the pharmacologic therapies we use, at 1 year, 50% of patients aren't even taking their drug therapy anymore. If you don't use it or take it, it doesn't work. And so your success rate for fracture risk reduction declines dramatically with use of hip protectors or medical therapies. There's also soft ones too. There's many different types. And certainly, many of us use them in certainly the high-risk patients. You'd also use assistive devices, rolling walkers, things like that to decrease falls risk. And also send your patient to neurology, movement disorder folks, PT, OT, whatever it takes to improve balance. Would you do a full workup to exclude myeloma? So the majority, it's about half and half, said yes. And I do, because you never know for sure, and it's certainly a treatable disease, or certainly you'd want to make that diagnosis. So as part of my evaluation, I'm at a tertiary medical center. I see referrals for this. I also have a inpatient fracture liaison service where I see all patients that fracture. I do order a immunofixation and either a urine or serum light chains with ratios. And the reason is that we find, not infrequently, every year I find a number of patients that have not been diagnosed as having myeloma. I just had one patient that I was evaluating for hypercalcemia, but also had osteoporosis. She also has light chain disease of a significant nature. So I always do this, okay? But I'm a compulsive person, too. So our take-home message here, bone mass is determined by the rate of bone resorption, osteoclastic activity, and the rate of bone formation, osteoblast activity, as we talked about. Multiple anti-resorptives are available. There's one osteoanabolic, as it's called, teriparatide. Zoledronic acid is associated with reducing fracture risk at multiple sites, meaning the hip, spine, and all clinical risk fractures in multiple different populations. The main advantage of zoledronic acid, it's certainly IV, it's annual administration, bypasses the GI tract for those patients that are at risk, or potentially have malabsorptive diseases, right? So we have to think of malabsorption, those patients that have rapid transit, other types of problems that would negate the absorption of an oral bisphosphonate. So what percentage of patients absorb oral bisphosphonate? What percentage of that pill is absorbed in those patients? Very little. So there are estimates of less than 1%. So any disease process that causes a problem with the GI tract or malabsorptive issues will affect this. And I don't use oral bisphosphonates in that class. Main adverse reactions, acute phase reaction, which includes in some patients myalgias and arthralgias, hypocalcemia, questionable ADRs haven't been proven yet in multiple meta-analysis. Arrhythmia, specifically AFib, is not documented at this time. Nephrotoxicity, got to give it right. And then potential skin reactions are rare cases of this. Hip protectors, yes, we use them, or at least I do. Okay, so let's just review this for a second. These are the actual anti-resorptives versus osteoanabolics. And as I mentioned earlier, osteoclastic and osteoblastic activity are coupled usually. And what we see with the bisphosphonates, denosumab, raloxifene, and even calcitonin is a reduction in resorption greater than osteoblastic bone formation. So there's a decline of both, but greater decline in osteoclastic activity. And therefore we have an improvement in mineralization in the remodeling space that's still there from the resorption phase. And we have decreased stress risers and decreased progressive bone loss and decrease in the disconnectivity of bone that would continue in those patients not provided a medical therapy. And this would be versus teriparatide, which actually increases modeling of bone. So within 3 to 6 months of starting teriparatide, we actually see increased biochemical markers of bone formation. These are the different medical therapies available. These are the registration trials. If we look at these, all the different medical therapies, and this is for vertebral fractures. This should say the VERT trial. I'm sorry, the HIP trial was for hip fracture risk reduction. So it's the VERT trial. It was a 3-year trial in North America and actually multi-center, including Europe and other regions of the world. And you can see fracture risk reduction in these therapies. With hip fracture risk reduction, we can see that it wasn't shown in all of the trials with all the medical therapies available. So with ibandronate, or the bone trial as it was called, 3 years of therapy in the registration trial was not shown to be effective in reducing hip fractures. Only in a subgroup analysis in those individuals that had very low femoral T-scores of -3 or lower did they actually see decreased hip fracture risk. Okay, If you look at ACE, the American Association of Clinical Endocrinologists, ibandronate, which is also called Boniva, a trade name, is not one of the primary drugs of choice for hip fracture risk reduction either. In raloxifene, that's a SERM that we'll talk about. So this is a 3-year trial. Only vert fractures were averted, okay, not hip fractures or other non-vertebral fractures. And also in calcitonin, only vert fractures were attenuated. With teriparatide, we have to remember that's 1.5 years of the study. That's all they had, because it was pulled by the company, actually, acknowledging with the FDA that there were osteosarcomas found in their rat population. And we'll talk about that. So it was only a 1.5-year, 18-month mean duration of the trial. And they saw significant decrease in vertebral fractures of 69%, but there were insufficient hip fractures as part of that study to say anything about hip fracture risk reduction in that group. Okay. Hip pad protectors. Ron, which one is this? I don't see any hip pad protectors in this patient. Is this just a corset? Are you trying to trick us?
Good surgery. The surgeons are good.
This is a great hip pad protector. So many women don't want to use hip pad protectors because they fill in the hip area, okay, and they don't look good in their outfits. This is what they tell me. So they don't want to wear them. We have to go through the different ones that are available, and hopefully they change their mind. And in this study, there was a significant reduction. But if you don't wear it, you don't gain benefit from them. Has anyone else heard that too from your patients? Have you heard the gentleman who has used them? Have any of your patients said, "I don't want to wear that big thing"? No, they probably don't tell you because they're not wearing it, right? I'm just kidding. You're very successful. Okay, case 2. So let's go to case 2 here. So this is a 70-year-old woman, and we've talked about this in the prior session. While watching TV, spontaneously develops acute back pain, mid-back, no specific radiation. We've gone through this. She was diagnosed as having a T8 fracture, no neurologic, good dietary intake, no significant alcohol or cigarette abuse, no excessive caffeine or sodium intake. Family history is negative for osteoporosis. But as you can see here, she has a T-score of minus 2.9 at the lumbar spine. Secondary etiologies excluded. So in this case, management of clinical vertebral compression fractures include pain relief, including narcotics, bed rest, back bracing, A or C. What do you think for the acute fracture? So most people believe that, one person believes that narcotics are indicated. 24 people believe that. Most people say A and C, so bracing, getting the patient out of bed so that they don't develop progressive disuse is important. And I agree with that. In other words, if you can, you would certainly wish to mobilize your patient as rapidly as possible with appropriate bracing techniques. Okay? But one of the important issues in this is that some people, no matter what you do, they may have very severe pain. You would require obvious narcotics, but you're not gaining any ground. The patient cannot get up out of bed, even with appropriate bracing techniques. Okay? And so there may be other protocols out there that we can use to mobilize those patients who have been in pain for weeks and weeks, and you cannot do anything about it, even with bracing techniques. You're not gaining any ground with them. Potential adverse effects of narcotics include cognitive dysfunction, falls narcotic dependence, and this should be easy for everyone, right? I want to see 46 clicks. So the answer is yes, it can produce major problems. What other problem is not listed here that's very common with narcotics? Exactly. So it's a very significant problem. So you'd want to try other analgesics, pain relievers as much as possible, but sometimes you're stuck. The patient has very severe pain. Well, there's other things we can do too. And so in this patient, is vertebral augmentation includes what we call vertebroplasty, kyphoplasty, vertebral stents. Are these possibilities? A and B, vertebroplasty and kyphoplasty, or all three? What else can we do in those individuals that are not improving? So I think most people here believe, and we're still voting, but that vertebroplasty and kyphoplasty have been used in these individuals. Vertebral stenting is where a surgical procedure is done and a cage, an inflatable cage, is inserted in the vertebral body and then inflated. Okay, so the cage actually increases the vertebral dimension. And then in some cases, cement is injected within the cage to increase the size of that vertebra. This is a newer technique over the past 3 to 4 years that have been employed by orthopedics, neurosurgery, and IR, interventional radiology. Okay? And during vertebroplasty, biologic cement is introduced under high pressure in the body of the vertebra. So it goes through both posterior elements, both pedicles, right into the vertebral body for injection. The risk of cement extravasation in the spinal canal or around the nerves is considerable. Risk of neurologic complications is low. What do you think? How many of you actually suggested vertebroplasty or kyphoplasty in your patients? Raise your hand. So maybe about 7 or 8 of you. Okay. So those that are using it believe that A, B, and C are correct. So it's true with vertebroplasty, it is under high pressure. Yes, there can be extravasation, so it's not infrequent when you do repeat plain films or MR afterwards, or even CT. But the risk of neurologic complications is not high, although it has been seen. I have not seen it myself, but there are cases of this. There's also cases of embolization of the cement through the circulation. And so there are potential risks. It's not innocuous. It also takes a surgical procedure, so you have to take the patient to the operating room for this procedure to be performed. Compared to sham procedures, vertebroplasty is associated with immediate, almost complete pain relief. The pain relief is significant in 3 to 6 months. 12 months after vertebroplasty, there is no significant difference in pain relief between the sham and a vertebroplasty. So this is 2009 data. Meaning prospective trials looking at vertebroplasty versus shams. What they actually did was they took the patients to the OR, but in the sham portion, meaning the placebo control, they injected the spines with the paravertebral spinal muscles with Novocaine and things like that. They didn't actually do surgery, but the patient did have a pinprick in the back, and so it was the sham. That was the placebo control group. All right, so we're still a couple people here. So, what do you think, Ron? Have you used vertebroplasty often?
Kyphoplasty mostly.
Okay, so in the data that was presented, and this was 2 prospective trials, so they showed that there was significant pain relief after the procedure. There was pain relief even in the placebo group, though, and that pain relief from the standpoint of long-term was no different in the long-term trial, meaning after an extended period of time, up to a year. There wasn't much difference. And so what these 2 papers did was to really decrease the utilization of vertebroplasty. Do you know a lot of people that still use it?
No, it's mostly kypho.
Yeah, so
at least where I am.
And so it varies. Recently, though, there have been a number of publications from the neurosurgical societies and interventional radiology with reanalysis of the 2009 data showing that vertebroplasty was no better than the sham procedures, saying they were flawed and that there were some problems with the studies and the way they were analyzed initially. And so at my center, both are used, meaning both vertebroplasty and kyphoplasty is still used. So the more recent data and the indications for vertebroplasty by the neurologic societies and IR societies in the United States is that vertebroplasty should be used. It's really interesting to see this new data coming out. And actually the indications are very different than what we've thought of in the past. So what are the indications for vertebral augmentation in this population? So most of us believe that you should determine if conservative therapy works initially, unless the patient is so incapacitated from pain, right? The patient cannot move no matter what you do. And there's an increased risk of disused bone loss, increased disused muscle mass, and everything that goes along with that, that over a period of time you have to reassess that patient over the first 4 to 6 weeks to see if you're gaining any ground. If the patient is unable to function at all, they have 2 or 3 vertebral fractures, you don't wait 6 weeks, okay? But the neurologic societies, their recent guidelines suggest anyone that requires it should receive it. It's very different than what we've been accustomed to from the other bone societies and other groups previously. Kyphoplasty, a cavity is created in the compressed vertebra, cement is introduced in the body of the vertebra under low pressure, and height may be partially restored in some cases. So that's one of the criticisms of vertebroplasty. You didn't see significant height restoration, whereas kyphoplasty was preferable in those cases. Retrospective analysis and people that do a lot of vertebroplasty actually say that yes, you can restore some height, and I've seen that as well. So in our present situation here, most people believe all 3 are true, and that's mostly what we see. Okay, changes in quality of life scales and undergoing kyphoplasty. So we'll use kyphoplasty at this point in time and say at 1 month we're considerably better in patients undergoing kyphoplasty. Benefit persisted for 6 months. False. This benefit persists for about 6 months. False.
I don't know where this came from. It's not here.
Oh, I see. Who put that in there? You did, right?
Randy.
Okay. We got the culprit. So take out false, please. Yes. Okay. This benefit is lost by 12 months. A and B, A, B, C, Please choose. Those that went ahead and included false, we'll give you a break on this one.
That's your entry.
So we're still moving ahead here. Okay. So firstly, with kyphoplasty, the long-term data shows that it is beneficial long-term. And that was seen in the prospective trials with kyphoplasty. The benefit was not lost at 12 months, and that the benefit persisted for quite some time. When these patients respond, for those that have not performed it or asked for neurosurgery, IR, or orthopedics to perform the procedure, when it works, patients get off the table and they have no pain. So it can be very dramatic in people. You would not consider it if there's significant vertebral plano, when there's no vertebral present, meaning it's like worse than a grade 3. There's hardly any vertebra present anymore. Okay. So, changes in back pain scores after kyphoplasty versus conservative care are significantly better at 1 week, significantly better with kyphoplasty at 24 months, associated with better mobility recovery. So most people believe that it's A, B, and C. So yes, these individuals have immediate, in the controlled studies, definitely this has been shown to be a benefit with lessened pain, and certainly long-term in the studies it's been shown, and there's better mobility and quality of life with these procedures. Is that what you've seen?
I don't see the B one as much.
Okay, at 24 months. You've seen it at 12 months.
Correct.
Yeah. So there's some debate in the kyphoplasty literature regarding this. But definitely at 12 months, this has been shown. At present, indications for vertebral augmentation include non-response to medical treatment at 2 weeks, non-response at 3 months, chronic severe back pain due to multiple vertebral fractures. Okay, we still have a few folks in there in the audience to choose. So most individuals believe A and C. So non-response to medical therapy over 2 weeks. Is that what you do, Ron? Okay, some of the physiatry people I work with try 6 weeks of therapy. Non-response to medical therapy for 3 months, that would be a significant amount of time in my book. Chronic severe back pain due to multiple fractures, so we could certainly consider in those individuals as well. Patient is unable to function. And so I would certainly go with A and C. You agree? Okay. Any questions about that? Yes?
You had a low level, they went through an acute phase, then you had this sort of chronic level. And some of the interventional people where I am, they'll do it up to a year later. Did you mention that? Or maybe I changed it?
So the question is, in your interventional radiology group, who they do the kyphoplasty, say, or vertebroplasty, they do it up to 12 months after the event. Well, So this is in the IR literature and their guidelines, okay? It's different than other guidelines. And I think you have to ask yourself, what's wrong with the patient? Does the patient have pain from an acute fracture or the biomechanical problems of that fracture caused in the spine? All right? Because now that fracture or fractures have caused a biomechanical change in the way that the patient's spine actually functions. Or is it still an unhealed fracture? So if it's not a healed fracture, that's different than the biomechanical pain that occurs due to fracture pain. Because now they're this way, and they have pain because of muscular spasm and things like that. Or is it true non-healing? Well, there's a condition called dynamic mobile fractures, in which some fractures don't heal. You'd expect fractures to heal over, up to a 6-month period of time usually. But there are some fractures that don't heal, and they keep on gravitating, they keep on moving. So, and we don't necessarily see them when the patient is flat on the table doing their cross-table lateral X-ray or their CT scan. In these people, in those people that have continued pain in that vertebra, and you believe they may have these mobile fractures. They're not healing, and they're actually moving. They're not melding together. In those cases, what we do is a supine lateral and then stand them up to see if it then collapses. Plain films. That's all you need. And in those cases, then you've documented this mobile fracture. And yes, they should have vertebral augmentation as part of their treatment, because they may never heal. So I would make sure when you examine them that you determine it is truly their fracture pain. You can do a repeat MRI to see if there's healing. You could do the supine lateral and standing X-rays to make sure they don't have this dynamic mobile fracture of the spine. Make sure it's not biomechanical, or they have other etiologies. They now have a retropulse fragment, right? They have something else that's in their spinal cord or spinal canal that's causing pain. Make sure they haven't changed in their neurologic exam, and there's something more to it that a vertebral augmentation will not help. They need neurosurgery, potentially. Okay? So you have to look at all these pieces before you say yes or no. As a clinician, that's what I do. Very good question. So a take-home message, vertebral augmentation, vertebroplasty. The cement is injected into the vertebra at high pressure. Kyphoplasty, a cavity is first done by a balloon, so it inflates the vertebra, and then the cement is introduced under low pressure with less of a chance of extravasation. Vertebral stenting, this is a newer procedure in which a titanium or other metal, it is a titanium metal expandable piece is inserted, a stent is placed in the vertebra, and then cement may be included in that procedure to harmonize that stent.
Do you use the vertebral stent in the grade 3s?
No, I've never seen it used. Well, in grade 3, yes, but not vertebral plana. So vertebral plana is when there's hardly any vertebra present. So that's more than just over 40% reduction. When you look at that X-ray, they just have the two end plates together. There's nothing in between. There's almost no vertebral body left. And so that would be potentially dangerous to try to find a space to place your trocars and inject a stent or the cement. And so it is not suggested. Also, when you do MRIs in those individuals, they commonly have retropulse fragments. They, not unheard of, have neurologic complications as well. And vertebroplasty or kyphoplasty in those people would not help their condition. You'd have to look at, whether they're going to have significant spinal cord or spinal canal problems, meaning neurologic problems long term. Okay, So vertebral augmentation procedures, that's to encapsulate what we've been talking about today. Prior to cement introduction, cavity is formed with vertebral augmentation. This is specifically for kyphoplasty, not vertebroplasty. Cement introduction, high pressure, low pressure. Stenting, low pressure. Risk of extravasation, high but low in the others. Okay, so this gives you sort of an overview of what some of us utilize to assist in our patients' mobility. This is an example of multiple vertebral augmentations. You can see multiple vertebra with the cement within the vertebral themselves. Okay. This may be a little extravasation outside the area. Here's a little extravasation. I'm not sure. I can't see from my angle. Is that extravasation?
It's quite a bit, yeah.
Yeah, I can't. I think there's extravasation right here.
Quite a bit, yeah.
Here and here, and I'm not sure here. So this is something that you want to be very careful of. Okay. So case 3.
Just one question about
Sure.
does that increase your risk of fracture at the level above and the level below where you're
The question is, if you if you use vertebroplasty or kyphoplasty or even stenting, does that increase the risk of fracture above and below adjacent vertebra? So some of us have actually seen, increased fractures above and below that. So I've seen that. If you look at the retrospective analysis of the trials by neurosurgery and other professional societies, they don't believe it. They don't see it. There's no difference in the placebo groups versus those that were actually taken to surgery and had vertebral augmentation performed. So the data right now is probably not, meaning from the studies looking at the shams versus those that actually had the procedures with kyphoplasty, for example, they're not seeing it. Have I seen it? Am I concerned? Yes, but I can't prove it.
Is the integrity of the posterior wall of the vertebral body routinely assessed pre-procedure, such as with a CT scan?
So prior to vertebral augmentation, you would always do an MRI. Okay?
Or is CT used?
No, I don't think so. You would use MRI preferably because you're looking at soft tissues as well, and you want to see if there's extravasated disc as well as the impact upon the spinal canal, spinal cord, whatever it is, neurologic status of the patient. So it's typical to do MRI. And if the patient has symptoms afterwards, you'd repeat it. Yes, please.
Can you comment on the benefit of sacroplasty to just replicate,
Sure. So the question is, what is the implication or the benefit of sacroplasty? So sacroplasty is doing the same for sacral insufficiency fractures. In the cases I've seen with sacral insufficiency fractures, the vast majority of them have healed, okay, unless the patient has underlying metabolic bone disease, okay? So what I do is before I send, if they come to me, I do a comprehensive metabolic workup, evaluation for underlying metabolic bone disease. And frequently, and this is not unusual, as all of you in the audience are aware of, they have vitamin D deficiency, they frequently have secondary hyperparathyroidism. In some cases, they have other underlying disorders. And you're only treating the symptom then by doing the sacroplasty, whereas if you treated the underlying condition, if it was, say, a mineralization disorder of bone, which is not infrequent, then you're going to get healing as part of that. I have not ordered a sacroplasty ever, personally. Have you, Ron? Have you seen it done?
Yeah.
Yeah. So again, I think we're dealing with different groups that have their own guidelines. So these individuals have their guidelines, and The other folks have their guidelines. I think you have to use good clinical judgment. As part of fracture service, I see patients that have vertebroplasties and they're sent home without anything done. They're not evaluated. Commonly, this is the most common thing that's seen. Before fracture lay zone services are put into place, patients typically are admitted for their fracture and sent home. Nothing is done. I worked in a long-term care facility. I worked at a rehab center. I've worked at a senior care inpatient, outpatient center outside the university setting in my career, and I see this all the time. Mrs. Jones is 85. She's had 5 different fractures in the hospital, out of the hospital, no evaluation. When you work up these individuals, they have multiple problems, multiple things that need correction. So the key issue for the sacroplasty, evaluate that patient first. See if they have a mineralization disorder. They have underlying metabolic bone disease. I had a patient I just saw in the in the outpatient clinic. They have iatrogenic hyperthyroidism, where the TSH is undetectable for years, overtreated for years. Okay, and the patient has hyperparathyroidism also. I mean, what is this? What is this about? Okay, the patient truly has underlying metabolic bone disease, and you want to do something about it to correct it, because your sacroplasty is only a fix. Just like treating the fracture with surgery, it's a fix. It is not evaluating the patient and treating the patient for their underlying problem. It's like a drop-down menu. Click, treat, out as quickly as possible. I'm sorry, I'm very, very, I really feel strongly about that if I haven't sent the message. All right. So, any questions about that? Okay. So let's go to our next case. This is a 72-year-old individual, morphometric vertebral fracture at T7, was diagnosed when the patient had a CT for pneumonia. This, as Ron said, is frequently not diagnosed or even evaluated or treated because everybody's worried about the pneumonia. Okay? Lives alone, mentally good, shape, weight steady, height 63, no significant clinical findings, but maternal history of hip fracture, which is very significant. T-score minus 2.6 at the lumbar spine. Okay? So, share the same basic formula. What is it? Did I go somewhere here? Yeah. Share the same basic formula. 2 phosphoric acid molecules joined to all bisphosphonate. Okay, I can't see. To a carbonate and 2 side chains. The side chains determine the inhibitory potential. Bisphosphonates on osteoclastic activity. The side chains determine the affinity of the bisphosphonate to the hydroxyapatite crystal. Okay, so we're going into the biochemistry of bisphosphonates. So I think most individuals are picking A, B, and C. So the 2 side chains, and it's true, the 2 phosphoric acids are connected by a carbon instead of oxygen. And these 2 side chains are really important and provide the variability of efficacy, avidity to bone, as well as the efficacy in the molecule itself as it proceeds into the osteoclast and affects the mevalonic cholesterol pathway. So that's how this actually works. So the bisphosphonates work on the mevalonic cholesterol pathway and inhibit the enzymatic action through this pathway, affecting the cytoskeleton of the osteoclast. Okay? And this determines the enzymatic activity and the avidity of the bisphosphonate to bone. Inhibits osteoclastic activity, induces osteoclast apoptosis, so inhibits osteoclast intracellular Farnesyl pyrophosphate synthase enzyme. I want everyone to say that with me. Together. It took me only 10 years to be able to say this. Ron got it in 1 year. It took me 10 years. So what do you think? I've already given you the answer, right? So in fact, you're absolutely correct. It either slows down the functioning of the osteoclast. Some believe it doesn't always cause apoptosis in bone biopsies, histomorphometry of bone. But the key issue is that the main activity of these agents, the bisphosphonates, is the inhibition of the mevalonic cholesterol pathway. Specifically, this enzyme is inhibited. And because of this inhibition, you don't have prenylation, as it's called, of specific proteins within the cell that are required for the integrity of the cytoskeleton of the osteoclast. The osteoclast doesn't function right. It doesn't do its job. So this is the main effect of the nitrogen-containing bisphosphonates. That's how they work. Orally admitted bisphosphonates, less than 3% are administered, is absorbed. Our irritants are excreted unchanged in the urine. This should be easy for you. I should expect to see 40-some clicks on this one. All right, so true. So remember, all the bisphosphonates, approximately 50% go to bone and 50% are excreted unmetabolized through the kidney. That's what happens. There's no liver metabolism. To a various degree, oral bisphosphonates have been shown to reduce fracture risk to hips, single new vertebral fractures, multiple morphometric vertebral fractures, A and B, A, B, C. Let's make this quick. I know you guys know this. So good, very good. And remember, when we talked about abandronate, also the trade name is Boniva, it was only in the subgroup analysis in patients that had femoral neck T-scores of -3 or lower that it was shown. And that's why it's not listed in the ACE guidelines as the primary most effective drug treatments. So raloxifene and abandronate are not included in that first tier of effective drugs for that reason. They both do not affect hip fracture risk. You have to do subgroup analysis to determine that. So if you really want a drug that decreases hip fracture risk in all the other populations, then you have to consider alternatives. Okay, various degrees, oral bisphosphonates have been shown to be effective in postmenopausal osteoporosis, osteopenia, men with osteoporosis, AC, ABC. So we're going with ABC. Mostly here. One person. AC. So this is one of the really interesting aspects of the original registration trials, because what happened was, in retrospect, they didn't. The reference population that they used for their T-scores for entry into the studies was a different reference base. It was a manufacturer's reference base for the hip. And then they converted to the NHANES 3 database, or reference database. And when they looked back then, they found that a significant proportion of their patients actually had osteopenia, low bone mass. So this was with alendronate, and it was with risedronate also. And so many of these patients actually had osteopenia. We see this also in men. This was effective in men as well. Okay. Any other comments, Ron? Okay. Oral bisphosphonates have been shown to be effective in patients who have sustained hip fractures, on aromatase inhibitors, patients with hyperparathyroidism. So we've got most of the folks here believing this, huh? Most of the folks believe this is effective in hyperparathyroidism too. All right, so basically, yes, it has been shown in studies, individuals on AIs, breast cancer, okay? And it has also been used, oral bisphosphonates especially, alendronate in particular, in published trials in patients that have primary hyperparathyroidism in which surgery is not indicated, okay? So in that case, it has been shown to decrease bone loss associated with that underlying metabolic bone disease. To decrease calcium, though, and to decrease parathyroid effect on calcium, you would also potentially use cinacalcet, Sensipar, in those patients. So, in fact, in the older literature, you would use a bisphosphonate and Sensipar in those patients that cannot tolerate surgical intervention for their primary hyperparathyroid adenoma. More recent data is showing that actually Sensipar may actually decrease parathyroid effect and stabilize bone mass too. It's some very recent data. Oral bisphosphonates have to be administered while the patient is fasting, can be administered after a fast of 2 hours, may be taken with other medications, all of the above, none of the above. Well, we're not sure. I guess people aren't sure yet. So how long do you keep your patients fasting before when you talk to them about taking a bisphosphonate? How long should the patient fast for? What's the suggestion? An hour. Is that agreed? Ron, is that what you do?
Yeah. Overnight.
Overnight. Okay, so you want them to fast overnight, so they take it first thing in the morning, correct? Okay. So certainly you'd want to have them fasting overnight, first thing in the morning. They take their medication, and then they take their food at least 30 minutes afterwards, okay? Can be administered after 2 hours, so they have breakfast, they wait 2 hours. Will that work? I don't think so, okay? Can be taken with other medications. So we talked about this. Anything, coffee with bisphosphonate, oral bisphosphonate, doesn't work. Orange juice, I thought, I can't stand tap water. I want to take my OJ with all that calcium. Okay, so they take it with OJ too. This is not food, it's liquid. Okay, anything will interrupt that very low absorption rate. So you have to be careful about what we explain. It's tap water. It's not with any fizz in it, it's not with sugar water in it, or anything else. It's tap water. Distilled is good.
There's so many in our area, at least, that have well water.
Yep, that's a good point.
And I think it's easier to tell them to get a jug of distilled water, keep it in the fridge, just to take their bisphosphonate.
So if you have well water, that's full of minerals too. And where I live in Chicago, there's plenty of other things in that water that you wouldn't even want to know about. I'm sure. Ron, you want to talk about Atelvia, Risedronate? So, yeah, that's one of the drugs that supposedly you can take it after meals, okay, and there's no interference with that. But there's no fracture data with that. It's all equivalency in regard to, absorption.
The principle is very interesting, that they use a chelating agent and the pH-sensitive envelope so that nothing happens in the stomach and the small intestine. The pH-sensitive capsule is dissolved. It releases the chelating agent, which is meant to go and hook up all other anions so that the residronate can sail smoothly across the intestinal mucosa. The only data that is available is that the BMD is increased to the same extent as conventional residronate. But as Sandy was saying, there is no fracture data. And it really goes against everything else we've been told about the bisphosphonates. What's interesting, I've used it quite a few times, the number of patients who develop GI adverse effects is equal, if not more, than the conventional oral bisphosphonates. But as I said, the only data that is available is that it increases the BMD to the same extent as residronate. Conventional.
Thank you, Ron. That's called bridging data. So many of the different formats for administration of the medical therapies we have are bridging. Causes the same change in BMD. So yes, it'll work as a surrogate marker for fracture risk reduction. Okay. Effects of orally administered bisphosphonates, upper GI, lower abdominal pain, diarrhea. What do you think? These are important things to think about when you're prescribing drug therapy. And let's see what we come up with here. So most people believe upper GI adverse effects or some believe this is the primary concern. Some people believe that lower abdominal pain and diarrhea can occur. Okay. What do you think, Ron?
I use oral bisphosphonates quite a lot, and apart from the conventional upper GI adverse effects, I notice quite a few patients develop lower abdominal pain. Typically, it's about 2 hours after taking the medication. The reason I think is, as we've seen earlier, less than 3% of the medication is absorbed, so 97% is not absorbed. It gets to the intestine, and then it gets in contact with the mucosa, irritates the intestinal mucosa, induces peristalsis, which induces abdominal colics, and the patient interprets this as lower abdominal pain. Haven't done a proper study on it, but what I find is if I make sure the patient 30 minutes after taking the oral bisphosphonates eats something, a high fiber diet, lower abdominal pain is reduced quite considerably. So my recommendation to the patients who have lower abdominal pain at least 2 hours after taking the oral bisphosphonate is to make sure half an hour after taking the tablet, they have a diet that is rich in fiber. So bran, cornflakes, wheat bread, a banana, any of these would help. And what they do is that they coat the unabsorbed part of the oral bisphosphonate and prevent the bisphosphonates from getting in contact with the intestinal mucosa, and there is no abdominal pain. Same thing happens for diarrhea, because the oral bisphosphonates irritate the intestinal mucosa, induces peristalsis, and the patient may develop diarrhea.
Okay, so these are not uncommon. They can occur, and we should be aware of it and take steps to ameliorate these problems. Okay. So bisphosphonates, additional adverse effects, impaired memory, hepatic impairment, acute pancreatitis, none of the above. All right, so everyone believes there's no history of these types of problems, and that's pretty characteristic. There are few cases of hepatic problems, but we don't know if they were actually associated with the drug therapy. Okay, very good. Okay, adverse effects include musculoskeletal pains, arrhythmia, and atrial fibrillation, uveitis. It's kind of a tricky one, isn't it? That's it? Everyone is not sure. Everyone else is not sure. So we talked a little bit about the acute phase reaction, myalgias and arthralgias that occur, primarily in the IV group, but I've seen it even in the oral bisphosphonate group. It's not that common in that group, but we see it. It is not uncommon when the IVs are given. So when IV zoledronic acid is given for malignancy every 3 to 4 weeks, this is much more common in these individuals initially, but then the frequency of these associations decrease, as we talked about on the second and third annual dosing of zoledronic acid. Arrhythmias stated to be increased in the initial Horizon trial, but looking at the extension trials and the meta-analysis of all trials with zoledronic acid, there is no definitive atrial fibrillation that can be associated in these patients. Uveitis, so we could say yes in the initial trial, but no in the meta-analysis of everything that's been written with zoledronic acid, which is specifically what we're talking about in the original registration trial. Uveitis, yes, that can occur. It's rare, but it does occur. And the uveitis can be, as we talked about, conjunctivitis. It can be episcleritis, scleritis, iritis, a variety of different things. And you certainly want your ophthalmologic colleagues to take a look at these patients. So our take-home message is they're effective at reducing hip fractures, vertebral fractures, other non-vertebral fractures. Orally administered bisphosphonates are exceedingly poor absorption rates. There can be adverse effects on the gastrointestinal mucosa, meaning the upper and lower tracts. They can certainly provoke problems to the point where we have to ameliorate those symptoms, as Ron had mentioned, with a high-fiber diet potentially. And then oral bisphosphonates are certainly available in generic formats. So we have very inexpensive forms of alendronate that are available at this time. Short-term, main adverse effects, as we've talked about here, ocular nephrotoxicity, be careful. Skin reactions, very few skin reactions, but they can be severe, including Stevens-Johnson syndromes have been described with them, but these are very rare conditions. Again, from the standpoint of possible long-term adverse events, which we'll talk about, not now, but in the future, there's a whole lecture series that we're going to give one session just on atypical femur fractures and osteonecrosis of the jaw. Okay, so let's go on to our next case. This is case 4, and this is our 52-year-old individual referred by ortho for a Colles fracture after tripping over a carpet. And so she's 52, surgical menopause at 35, for endometriosis, never took HRT, asymptomatic up to the time of fracture. She's sedentary, so she doesn't do anything other than watch TV and do a few things around the house. Well-balanced diet, calcium and vitamin D intake, Our calcium intake's about 1,200 milligrams, 6 cups of coffee, 6 sodas a day, 1 martini, 2 glasses of wine, no smoking, family history is negative, T-score at lumbar spine -2, T-score at the total hip -1.3, and femur neck T -1.6. So our first question is raloxifene. Let's talk about raloxifene. It's a SERM. And it is a selective estrogen receptor modulator. How many of you prescribed raloxifene? Okay, so quite a number. Is it an anti-resorptive? It inhibits. Does it inhibit osteoclast? We talked a little bit about these drugs that inhibit osteoclastic bone resorption. What do you think? Give me a click. Don't be afraid. Click. All right. So yes, it is a SERM, a selective estrogen receptor modulator. So it's agonistic in one way on certain tissues, and it's antagonistic on others. So, for example, it works positively on bone, like estrogen, as an anti-osteoclastic drug. It prevents osteoclast function, like estrogen does. And on breast, it is opposite. So it actually decreases estrogen-positive breast cancer in those at risk for it. So it is prescribed for that specific reason. It inhibits mature osteoclasts just like estrogen does. Same format. Now, what about the control studies of raloxifene? Does it reduce hip fractures, vertebral fractures, non-vertebral fractures? So this is how do we prescribe it? When do we prescribe it? Patient comes in with a hip fracture. Would you prescribe raloxifene? We're still wavering here. So, okay. So, number one, it has never been shown, raloxifene has been never shown in the Moore trial, as it's called, to reduce hip fractures. It has never been shown to decrease non-vertebral fractures either. It has been shown to decrease vertebral fractures. Okay? So, it's a real key issue depending upon what your patient's experiencing and how you use this drug. The main potential risks or complications: hot flashing, deep venous thrombosis, leg cramps, AB, ABC. Choose. Please choose. If most of you are using this medication, you should be able to click this. All right. So the majority have it correct. So hot flushes occur mostly more so in younger women that are provided this therapy than older postmenopausal females. Deep DVTs, especially in those individuals who have underlying etiologies or potential for it, like factor V Leiden deficiency states. Leg cramps, more so in the Moore trial in those on therapy versus those that were on the placebo group. Okay, and also, so all three would be considered potential risk factors or adverse events, I should say, with raloxifene. Other complications with raloxifene. Please choose. right, so we have mostly gallbladder disease and hypertension, urinary incontinence. Now, most of you are using it, so what you're saying to me, there's no urinary incontinence seen with this drug, that you do see hypertension with this drug. Have you seen this, Ron? I haven't seen it. You're seeing it? Okay. What about gallbladder disease? So in the actual trial, there was a slight increased risk of gallbladder disease in these patients versus the placebo group. Okay? What? Has raloxifene been shown to reduce the risk of breast cancer, dementia, and coronary artery disease? Please choose. All right. So most of us are going with breast cancer. And of course, that's what we talked about earlier. So in the Ruth trial, in the Moore trial, the original registration trial for postmenopausal osteoporosis, estrogen-positive breast cancer is definitively and dramatically reduced in incidence. Okay, and it is prescribed in individuals, women that are at high risk of this, postmenopausal women. It has a neutral effect on lipids, so that's good, and has been shown not to improve dementia or cause it. Fasting, how do you take it? Empty stomach, no other drug therapy, 6 ounces of water. All right, so people believe none of the above. Is that right? That's right. Okay, you agree. Estrogen, not approved by FDA treatment, postmenopausal osteoporosis. Approved for FDA prevention of osteoporosis. Is only approved if given for a shortest possible time in the smallest possible dose. A, B, C, we got 3 in here. You got to make a choice. All right, so people are tending to include all 3. So is estrogen replacement therapy, either E alone or estrogen and progesterone agents in those individuals with the uterus, is it used for prevention and treatment or one or the other? That's the key issue here. Is it really? It is not indicated for the treatment of osteoporosis. Okay? It is not indicated for the treatment. It is indicated for the prevention of osteoporosis. That's the FDA-approved use of hormone therapy for osteoporosis. Yes?
You mentioned dose there. What's the smallest dose that's been shown to work for prevention?
I haven't defined it.
I don't think anyone's defined it. A low-dose transdermal is also approved for the use too. Very low-dose transdermal estrogen is approved for this use. That's in the latest NAMS, North American Menopause Society's recommendations that came out, I think, in 2014 or 2012 or 13. So if you want to look at all the different estrogens that are available and what has been suggested by NAMS, then that would be the place to go. And yes, low-dose transdermal is suggested too, lowest possible oral dose to decrease potential side effects. So that it's been shown to be of benefit. Now, there is a dosing study looking at Premarin and the different doses that are available, and you can see a dose effect on bone. With the higher the dose, the greater the effect. But what the FDA is suggesting, and what NAMS is suggesting, at least at this time, is to use the lowest possible dose for the shortest period of time because of the potential risks of it, which are dependent upon the underlying processes in that individual. It all has to be individualized to the woman. In other words, is there heart disease in the family? Is there breast cancer in the family? There's none of those issues. How long do you use it? Well, most people would use it for 5 years or less, long term. Okay, but then again, you have to look at each individual to determine what are their postmenopausal symptoms and everything else that goes along with it to make that individualized approach in every single woman that you prescribe estrogen. Okay. Well, compared to placebo, estrogen has been shown to reduce the risk of hip fractures, clinical vertebral fractures, osteoporotic fractures, all osteoporotic fractures. What do you think? How many of you prescribe estrogen? Okay, so I see there's about 12 people up there. Okay. So the WHI, that very large prospective trial, definitely showed hip fracture risk reduction. Also, retrospective analysis looking at many other studies, Nurse Health Study, a variety of other trials showing a definitive benefit. Clinical vertebral fractures and osteoporotic fractures as well. Okay. When discontinued, the positive effects of estrogen on bone are maintained for at least 5 years, rapidly decrease. So say you prescribe it, and now it's time to go off, to discontinue drug therapy. What happens to bone? What happens to fracture risk? That's what this is asking. All right. So yes, the effectiveness of treatment is diminished dramatically. And what happens is bone mass decreases dramatically. And if you look specifically at biochemical markers of bone resorption and formation, specifically they change dramatically. So you see an upswing after discontinuation, and increased fracture risk is lost. Increased fracture risk occurs frequently. Not frequently, but rapidly. When administered for women more than 5 years after the menopause, estrogen increases the risk of dementia, including Alzheimer's, increases the risk of urinary incontinence, increases the risk of coronary artery disease, B and C, A, B, and C.
If you skip 6 and 7, it's after break. No, because break is at 12. See, break is at 12:15. Okay, and he's doing 4. He's doing 4 now. 5 is important. Okay. 6 is not that important. 7 is not that important. Okay. So if he does 5, and then after 5 we jump to 8.
Okay. Yeah, we'll just
just do it very quickly. Yeah. I'll tell them, but if you do it very quickly, while you do it after.
Okay. Okay. So most people believe it increases risk of coronary artery disease. So certainly in those individuals with increased risk. Okay. Do you believe that? Okay. So there was increased risk, and certainly there was increased incidence of stroke in certain individuals with in the WHI. And there was certainly DVT, increased risk as well. No, it's not coronary artery disease, it's stroke. So stroke. Yeah, it is questionable. Anything? Yes.
Do you mean by that question, breast newly administered after 5 years of menopause, or after 5
So this is long term. So this is a gap.
So this, you get on it for 5 years, now you're stopping, or you haven't started before, and you're starting at 5 years?
No, when administered within more than 5 years after the menopause. So they haven't been on anything. So that risk is different. So there's a difference in risk. If you start estrogen immediately at the time of menopause versus after. Okay? The risks are different. When administered women within 5 years of estrogen significantly reduces risk of vertebral fractures, risk of hip fractures, risk of non-vertebral fractures, none of the above, all of the above. And most people believe that it is all of the above. And yes, it is. Okay? So the take-home points, raloxifene is a selective estrogen inhibitor modulator. Placebo-controlled trials show it decreases vertebral fractures, but not other fractures. Main adverse effects of raloxifene include hot flashes, deep venous thrombosis, and leg cramps. It's not approved for the treatment of osteoporosis. Estrogen is not approved for treatment of osteoporosis. It's approved for the prevention of osteoporosis and to be given for in the smallest dose, shortest period of time. Yes?
So how would you treat case 4?
Let's go back to case 4. Yeah. So how would you treat this patient?
I assume that you're using raloxifene and estrogen as examples. Those are the two things that you would think of treating this woman.
Right.
Raloxifene doesn't have any non-vertebral data, right?
Right. So she had a Colles fracture. So would that prevent non-vertebral fractures in that patient? There's no data on there's no data, but estrogen, if you wanted to prevent fractures, if this was a prevention strategy, but this is not the indication for it. If the patient already has a diagnosis of osteoporosis, because she fractured her radius. If you believe... No, I'm not saying I would choose raloxifene. I would not choose raloxifene in this patient. Okay? And I wouldn't choose estrogen in this patient. Okay. Anyone would like to choose either of those medical therapies? Ron?
Yeah, we didn't say that tamoxifen is the best indication for her. We're just using this opportunity to talk about tamoxifen.
So would you treat this patient at age 52 with anything? I know she has osteoporosis based on...
Well, she has osteoporosis.
How would you treat her, though?
She's 52, right?
Right. But she has significant lifestyle modifiable risk factors, too. So you'd have to say, look at her family history. There's no family history, but she drinks significantly. She takes soda. 6 cans of soda. She drinks 6 cups of coffee. So you want to modify all of the other issues, too. And and her family history is negative for osteoporosis. She doesn't have that. She has osteopenia, but she fractured her forearm. So I'd be absolutely sure she doesn't have a mineralization disorder of bone, do a metabolic workup, because vitamin D deficiency is frequent, correct everything. And then basically you'd want to consider appropriate intervention in her.
Would you yourself put her on anything at this point, or would you just do the modifying that you're talking about? Because that's what I think I would do.
I think I would probably recheck her bone density if she's able to correct her modifiable risk factors, okay? Because she's only 52. The issue is that we don't know where her bone density was prior to this. So she had a surgical menopause at age 35. So there's debate on how much risk is based on early surgical, medical, premature menopause. There's some recent data suggesting it does not influence fracture risk. Interestingly enough, some recently published data and discussion. So we don't know whether the patient didn't model bone sufficiently, did not reach peak bone mass, I should say. That's a preferable term. At 35, she had a menopause. So did she really reach her genetic potential at 35? And that's possible that she didn't. If she's been drinking and if she smoked or did not consume any calcium, she never potentially got to her peak genetic potential. So that minus 2.0 at her spine could be because of that. And so this is potentially a long-standing process in this patient's case. I'd want to change her modifiable risk factors and then watch her bone density after that, see if it changes, see if she improves in regard to bone mass. If not, then I'd consider therapy. Yes?
Do you do the DEXA then at 2 years?
So when do you do bone density testing?
After lifestyle top?
So how long does it take for bone density to change in a patient like this? Say if you find a vitamin D deficiency, which is likely in this patient, you correct that, you correct calcium intake, decrease alcohol, all of those factors. What is absolutely necessary to know whether a patient has sustained a change in bone density? So you'd have to know at the bone density testing center that you depend upon whether they have done a precision assessment and a least significant change. Because if they haven't, you don't know where that patient's bone density is going. So with an average bone density testing center, we think of this as a precision error of around 1%, which is very good, which provides us with a least significant change of approximately 3%. That means that that patient has to have a change of 3% or greater to be meaningful, meaning that intra-individual variability of testing using DEXA is about 3%. So that you then have to say, okay, how long would you wait to repeat your DEXA? Well, you have to know the least significant change. And if it's 3%, I would say, even if she gained 1 or 2%, you won't see any change in the first 12 months after therapy. So if I have a least significant change of 3%, I'd wait 2 years.
How much weight would you give to the fact that she possibly has endometrial implants in the abdomen that were not removed with surgery? Would you give that any credence or thought that you're treating her with estrogen alone, that she might have implants?
Can you repeat that?
Would you give any credence to the fact that she had endometriosis, so she very likely has implants in her abdomen?
Implants. What kind of implants?
Endometrial implants.
Mm-hmm. I don't think so.
Well, one of the things we haven't disclosed about this particular patient is that it turned out later on that she had Crohn's disease. Okay, and that was responsible for her leukemia. But we use it here just to anchor naloxone and to explore the use of naloxone. But ultimately, when she was fully investigated, it turned out that she had the Crohn's disease.
Okay. All right. So we have to move on here. So this is our next case. This is a 68-year-old white WW, I should say, asymptomatic, T-score minus 2.8, left total hip. DEXA scan was done on the routine screening, T-score minus 2.8 at the left femoral neck. Asymptomatic, normal physical findings, lab, normal. Family history is negative for osteoporosis. So let's talk about rank ligand, we're going to talk about one of the other medical therapies. It stands for receptor activator of nuclear factor kappa B ligand. It stimulates osteoclast precursors to fuse and become multinucleated. It activates mature osteoclasts. So what is rank ligand? How many of you use denosumab? So at least half. So you should know this. We should have at least 15 clicks. So most folks are either saying A and B or A, B, and C. So the debate is C, activates mature osteoclasts. So rank ligand is generated by the osteoblasts, and it talks to the osteoclasts. And it causes stimulation, it causes all of these factors to occur. It stimulates precursors to become multinucleated. It activates mature osteoclasts as well. And so the osteoblast not only makes rank ligand, which connects or binds with rank on the osteoclast to activate them, but the osteoblast also makes or synthesizes and releases osteoprotegerin, which is absolutely opposite to that. So the osteoblast makes both, an inhibitor to its own synthesized rank ligand. And so there is a ratio, an effect in the body from the standpoint of, for example, hormones. So if you have adequate estrogen, you actually see a ratio that's adequate enough for the osteoblast to produce sufficient osteoprotegerin so that the rank ligand does not activate osteoclastic activity, in simplified terms. With the menopause, we see a decrease in estrogen and a release of the decreased production of osteoprotegerin, an increase in rank ligand production, and an activation of osteoclastic bone resorption. And that's why we see increased bone resorption and osteoclastic activity at the menopause, or andropause too, when males have male hypogonadism. So denosumab is a nonspecific antibody to rank ligand, or does it prevent activation of pre-osteoclasts? Does it prevent the maturation of osteoclasts? Prevent activation of osteoclasts. What is denosumab? What does it do? So in fact, most individuals believe it performs all of these functions. And so it's an IgG antibody to rank ligand, and it prevents the activation of those pre-osteoclasts as well as mature osteoclasts that actually decrease osteoclastic bone resorption. So that's how this functions, this antibody functions. How is it administered? Is it sub-Q? Is it for osteoporosis? Is it administered every 3 months? Is it approved for prevention of osteoporosis? A and B, or A, B, and C? So the majority of people believe it's administered subcutaneously. How often is it administered? Perfect. And is it used for prevention of osteoporosis? Perfect. So it's for the treatment of osteoporosis. There's no data showing it can it's used for prevention. There's no prevention data.
What's your thoughts about the oncologist using you have to have people on estrogen blockers?
So aromatase inhibitor use. Yeah. So that's for secondary osteoporosis prevention.
Correct.
You know, that's frequently used by them. I agree.
In my community.
Yeah, it's in my community as well. I think that it depends upon the clinical situation. It depends upon whether the patient has supervening factors that require sub-Q and not oral medical therapies. Okay, in the treatment of their potential loss of bone mass. There are very few guidelines in regard to the use of medical therapies that we have in osteoporosis to prevent osteoporosis development with aromatase inhibitors. There are some new guidelines from Europe. The oncologists have old guidelines from, I think, 2007 regarding prevention of osteoporosis. But there's no guidelines that say that you have to use or should use denosumab per se. I think it's individualized for the patient. It is certainly used, it's been used, and certainly other agents have been used as well in these patients. I think it's effective. I believe it's effective. There's no doubt about it.
Why would it, if it prevents osteoporosis, I mean, if it is used for osteoporosis, why would it prevent it?
It hasn't been shown to prevent osteoporosis.
It hasn't been shown, but it has been attempted to be tried.
It hasn't been studied, basically. There's no registration trial, so the FDA has not approved it for prevention. Okay?
I think we need to differentiate prevention of osteoporosis from prevention of drug-induced osteoporosis.
So, in other words, in the patients that you want to consider prevention dosing, like the postmenopausal female, would you use denosumab to prevent osteoporosis? And you could say, well, sure, it works in the treatment, but there's no data in those patients. Okay? In regard to glucocorticoid therapy, would you use denosumab for the prevention of osteoporosis from, say, high-dose glucocorticoids? There's no data. The company did not do any trials with denosumab in glucocorticoid-induced osteoporosis. Does that mean the drug wouldn't be beneficial in those different categories? Nobody knows for sure. Okay, it's not been proven. It's not approved for the use in those situations. Okay? So, have placebo-controlled trials shown that denosumab reduces the risk of hip fractures, vertebral fractures, non-vertebral fractures? Please choose. All right. And yes, it has been shown to be effective in reducing all of these fractures. Can it be administered in patients with impaired renal function? So we talked about zoledronic acid. You wouldn't want to use bisphosphonates in individuals with creatinine clearances of less than 35, specifically zoledronic acid. What about hypocalcemia? Is it contraindicated in patients with hypercalcemia?
We've got only one more after this. One more case. Just one more. Then there's a break. And then lunch. Oh, so I don't finish all. No, you jumped to case 9. I'll finish later.
All right. So most individuals have picked A and B. And the answer is yes, A. It's one of the drugs that we do have available as an anti-resorptive in those individuals with impaired renal function. It is contraindicated in patients that have hypocalcemia for the same reason as the bisphosphonates. Okay, so you wouldn't include B in this. I mean, you'd say that it is contraindicated, so you want to include B. So all the E's are incorrect because it produces the same immediate effect on bone remodeling. So if a patient has baseline vitamin D deficiency, borderline or hyperparathyroidism or combination, has low normal calcium, serum calciums, you're at high risk for potential hypocalcemia because you're shutting down bone remodeling within a day or two. So this is so potent of a drug, it decreases bone remodeling within days. And we see that in select individuals with hypercalcemia. And it's not contraindicated in the individuals with hypercalcemia. All right? So, denosumab is effective in postmenopausal women with osteoporosis, postmenopausal women with osteopenia, men with osteoporosis. So we're split pretty much. What do you think, Ron?
I would have gone for A and C. D.
Yeah. So I think we would go with A and C. It hasn't been used in individuals in the trials with osteopenia. Now, does that mean it cannot be used or it hasn't been used in those with osteopenia or could be used? It goes back to the issues that we talked about in the FDA-approved trials. It is not FDA approved for osteopenia alone. Okay? If you had and that's a pretty broad category, as Ron had mentioned. It's T minus 1.1 to T minus up to minus 2.5. So does it really work in individuals that have a T-score of minus 1.2? Does it really make a difference in increasing bone density in those individuals who just have slightly decreased bone mass, okay? Osteopenia, remember, is not a disease. It's a bone density term. It is a radiologic term for decreased trabecular markings and cortical shell decrease on plain film radiographs as well. But in our terms, in bone density terms, osteopenia, it hasn't been shown to be effective, just like oral bisphosphonates in people that are just in the osteopenic range, just into that range. Could it be used? Sure, but it has been shown to be of definitive benefit. Now, is it in the management of low bone mass in patients with cancer-related bone demineralization, RA, corticosteroid-induced low bone mass? What do you think? So as we talked about before, we got to move on. So we're not sure. It hasn't been shown in corticosteroid-induced osteoporosis to be effective. There's no registration trials in glucocorticoid-induced osteoporosis. What about cancer-related bone demineralization? Okay. So yes, so it has been used in the skeletal-related event studies as compared to zoledronic acid. And what about RA? Ron? Yeah. So there's certainly benefit in A and B. But there's no data on glucocorticoid-induced osteoporosis. And remember, they haven't done the study. We're not 100% certain If you can't use the other drugs, though, what are you going to do? I mean, you're clinicians. You have to think out of the box also. Main adverse effects: flatulence, increased risk of infections, back pain. What do you think? A and B, we're going with some A and Bs here, mostly increased risk of infections. Okay. Now, back pain was slightly increased in the initial Freedom trial in the DMAP group, not overall long-term in the extension studies or anywhere else. It's really cellulitis that was seen in the Freedom trial. Okay. That was the original trial. However, in the Freedom, and this is with cellulitis only, and this in the Freedom extension trials, meaning the long-term trials with this, it was not seen. And a recent review of infections and infectious events, and not only the Freedom trials and the other trials, there was no relationship between this AE and the timing of injection or the effect of it, meaning the duration of denosumab administration. There was no correlation with that at all. The package insert states that patients on immunosuppressive agents or with impaired immunity must be considered for increased potential risk of serious infection. So you have to look at that as a potential. Not that it will occur, but you have to think about that. Okay? The following are true about denosumab adverse effects: increased back pain, musculoskeletal pains, insomnia, none of the above. All right, so I think we can say that very few cases of increased back pain. These are just very small numbers. The increased musculoskeletal pain is part of that effect. Yes, that has been seen with the influenza-type reaction that is also seen with primarily the IV bisphosphonates. So that could be, if you were going to associate with that, then yes, it is part of the myalgias and arthralgias. I've seen that in patients as well after denosumab. It's not that common, but it does occur. Discontinuation, increased bone resorption, does that occur? Decreased BMD, increased markers of bone turnover. So once you discontinue denosumab, what happens? And so everyone believes that it's A, B, and C, and so it is true. You have increased bone resorption. So within 6 to 9 months, you see a reversal. Actually, you see it within 6 months or so. The biochemical markers of bone resorption actually go above the baseline, meaning the zero, the average bone density result in those patients. So there's a rebound effect, and they actually have increased bone resorption after discontinuation of drug therapy. There is also a decreased BMD that occurs, and increased markers of bone turnover, so formation and resorption markers. So if you're going, so this is really a key issue as distinguishing this drug from, say, the bisphosphonate drugs that you potentially would give over an extended period of time and see a long-term effect of those bisphosphonates because of the avidity to bone. They're still stuck to bone. They're embedded in bone. And as part of the resorption process, you're digging out old bisphosphonate that had been embedded in bone as part of the remodeling process, even off of bisphosphonates after they'd been on bisphosphonates for quite some time. But with denosumab, with raloxifene, with those two medical therapies, and even estrogen, once it's out of you, there is a rebound effect and increasing bone resorption and decreasing bone mineral density. So when we're going to talk about the drug holiday that was brought up, and we're going to talk about that soon, you have to consider that there is no drug holiday with this, meaning that the effectiveness is lost.
We can skip the next session, and skip this.
Okay.
9.
Okay, so we have to,
The last case.
we have to, last case, and then lunch. Okay? Okay, so we're going to go on to our 68-year-old patient, T-score osteopenia at the right total hip, was found on vertebral fracture assessment to have a T8 wedge compression fracture. The patient obviously has T-score in the osteopenic range. Wedge fractures were found at T8, but also L1 and L2 moderate crush fractures were found. So the patient has multiple fractures. So in this case, what therapy? Is this the wrong case?
Can you get 9?
Oh, am I in the wrong case here?
It's case 9 that we're going to do.
Oh, okay. Can you get case 9? All right.
This one.
Okay. Sorry. So we're moving ahead to finish before lunch. Okay. 86-year-old presents with her daughter, has been diagnosed as having osteoporosis. This is the patient whose mother also fractured her hip. A natural menopause of 50, no HRT, no excessive anything. She has a T-score of minus 3.2, vertebral fracture assessment, multiple vertebral fractures. Okay. So, given her age, the following are true. Given the patient's age, given her age, there's no reason to treat her osteoporosis. What do you think? Okay. Her risk of fracture is quite low. The adverse effects of most medications outweigh any potential benefit, A and C, or none of the above. And when you look, while you're thinking about this, if you look at the bone density data in the super elderly, in the 80s and the 90s, those individuals, we see actually a tapering off of bone density testing in the elderly of this category. People are not doing bone density testing in these individuals. It's very interesting. All right, so it's none of the above, correct. Teriparatide is recombinant human parathormone, 1 to 84. Is it administered by daily sub-Q injection? Is it stimulate osteoclasts? A and B, A, B, and C. This is a trick question, so be careful. Ron is doing this. He's tricking you. He's trying to trick you. I'm not doing any of this. What do you think? So most individuals believe it's A and B. Some believe A, B, and C. Remember, teriparatide, what does it do? It's a direct osteoblastic stimulator. So it stimulates bone modeling, just like young in age, okay? Then after the first 6 months or so, then sure, there's increased osteoclast activity, but more osteoblast activity, called the anabolic window. But it is truly 1 to 34, not 1 to 84. So that was the trick. Ron was trying to trick you, not me, okay? And it is administered, obviously, by sub-Q. That's why he wanted to move on to question 9. He wanted to trick you. All right. It induces large increases in BMD of the spine, femoral neck, distal radius. Where does it work? Does it work at all sites? So you're going to do your bone density. What do you expect to see? How many of you order teriparatide? Raise your hand. So a significant number of individuals. Where would you expect to see a response? Large. He said, remember, this is also tricky. Ron is very tricky today. So he said large increases. So I'm trying to help you. I'm trying to help you. All right, so what do we have here? So most people believe that you're going to see large increases at all sites that you would measure. And the answer is spine. So at the spine, depending upon the data you review, anywhere from 10.8 up to 13% increase at the spine during the duration of the study. At the femoral neck, maybe 3 to 4% increase. At the distal radius, no change or decrease. Okay? Decrease because maybe increased porosity, but it's not. But there's decreased fracture risk noted at the spine. There's no doubt about it. And let's go on. The gains in BMD when teriparatide are discontinued. Make your choice, please. So again, it's given for 2 years, 24 months. That's the FDA-approved treatment protocol. If you stop the drug, does this mean the patient is on a drug holiday? Do you want to give them a drug holiday, meaning a temporary reprieve from medical therapy once they discontinue Forteo, or also that's the trade name for teriparatide? So most individuals are voting here. Let's see. We're going with A, B, and C are maintained if bisphosphonate is administered, are maintained if denosumab is administered. A and B, 2 people chose A and B. Are rapidly lost. Okay? So when you look at this with with teriparatide, yes, if you stop that drug, within 2 years, all bone density accrual is gone. The fracture risk reduction with all these agents, with this agent, is not immediately lost. Even after 18 months, there's still differential fracture risk reduction, but you're going to lose that benefit over time. So that's published data. If you use a bisphosphonate, or if you use denosumab, meaning Prolia as it's called, would you retain the benefit of the accrual of bone density and the anabolic effect? What do you think? Has it been proven with bisphosphonates? And the answer would be okay. So the answer would be with bisphosphonates, it's been proven. Absolutely proven. So you retain the effect of it. Now, I don't remember any denosumab trials, but yeah, we don't. Again, there's no registration trials looking at this, but all of us do use denosumab after teriparatide to preserve the benefit and actually decrease fracture risk and bone accrual. Let's go on. Teriparatide increases bone density, potentiated if a bisphosphonate is concomitantly administered. So some people want to use both drugs together. Potentiated if denosumab is concomitantly administered. In women, potentiated if raloxifene is concomitantly administered. And the answer is none. So we don't suggest that you use both types of medical therapies together. It has not been absolutely approved. It's not been approved, and the data shows that the single drug therapy alone is preferable. And then after you utilize the drug, then you use an anti-resorptive or other agent to secure those gains long term. Does it reduce the risk of hip fractures, vertebral fractures, all types of fractures? So what do you think? A, B, and C, or vertebral fractures? We have 2 people voting. So the answer would be it reduces the risk of vertebral fractures. Remember, we talked about that. Because the study was terminated by the company because of osteosarcomas in rats at an early stage, the study only mean time frame was only 18 months. So the median was 19 months. So they didn't have a chance to see the full effect of the drug over a usual registration trial, which is 36 months of duration. Okay. Patient adherence with daily sub-Q teriparatide, what do you think? What have you seen, Ron?
Mine is quite high, actually.
So think about it. Here you have a patient injecting. Do they really want to inject themselves? No. But what does the drug cost? $1,400 a month. And if they're paying, yes, I know, it's very expensive. That's the retail cost. So would they want to give themselves the drug? You're darn sure. If they're going to spend out of pocket maybe a couple $100s a month for that, you're going to be sure that they're going to be taking it. So I see very good adherence to therapy with it because of those reasons. Okay. It is contraindicated in people that have radiation therapy in the past 12 months, patients who receive radiation therapy in the past 3 years, patients who receive radiation therapy in the past 5 years, patients who have received radiotherapy in the past 10 years. So the answer would be E. So it's any time. So radiotherapy to the body includes the skeleton as a contraindication. Osteosarcoma. So let's talk about osteosarcoma with teriparatide. It's been observed in Fisher 344 rats only. It's been observed in several animal studies. Has been reported in humans as a marginally higher rate than in the general population. So your patients see this on the internet. When you say, I would like to treat you with teriparatide, they're going to run to the internet like everybody does, and they're going to see osteosarcoma. I'm going to get a tumor. I don't want to take this drug. Okay, so what is the real data? So it was actually seen in the Fisher rats. These are rats that were prescribed up to 64 times the equivalent dose, huge doses in these rats. These were before the rats, their epiphyses never closed. They kept on growing bone. And on the higher doses, it had a total osteosclerosis of their skeletons. So it's a totally different model, okay? And so it's never been seen even in primary hyperparathyroidism. In severe primary hyperparathyroidism, there's a very high level of PTH circulating. In significant cases, you have approximately like an 8-fold increase in PTH, meaning 1 to 84 parathyroid hormone, and there's no osteosarcoma seen. In the over 1 million people that have taken teriparatide, there's no osteosarcoma seen with this drug. Main adverse effects. What do you think? So basically, we have here musculoskeletal pain, diarrhea, headaches, all of the above. What do you think? Do you see I've never seen musculoskeletal pain. Matter of fact, it's very interesting in those patients that have arthritis pain. It seems to diminish and this is just personal observation, have you seen it? It actually decreases their spinal pain from other etiologies. And that's just personal observation. But it appears that spinal pain, musculoskeletal pain actually is diminished in my patients, many of them. You can see occasional nausea. Nausea is one of those issues. The question is, could this be transient hypercalcemia that occurs? And the answer is yes. And it's transient. You'd want to administer your Forteo, say, in the morning or at night. And then you would do your laboratory in the morning. If you're going to repeat a serum calcium beyond that acute peak administration and serum level. Okay? Headaches occur as well in some of these individuals, but you can ameliorate these symptoms by taking it in the evening time frame. Okay? Anything else? Let's see.
We can skip this question.
Okay. Okay. So this will be our last question. Osteosarcoma affects 1 in 250,000 adults. It's much higher in patients on teriparatide. Risk is increased if the patient is also on raloxifene. What do you think? And that's true, but it is not associated with teriparatide treatment. So the risk, there is no change in risk if the patient's on treatment also with raloxifene. We don't use the medical therapies together. Okay, so we made it through. Okay.
The take-home messages are in the curriculum.
Okay, so in your curriculum, the take-home messages are also there. All right, so Ron, do you want to...
So thank you very much. Sorry we kept you 15 minutes later. The next session is at 1:30. We're going to talk about monitoring. And if you've noticed, the same cases that we carried through. So some of the cases we couldn't do at the first session, we did in the second, and the ones we couldn't, we'll do in the third session.